All right, so now we're going to talk about hemostasis. We've talked about all the different formed elements. We're going to move on to hemostasis, which hemostasis is the process by which the body seals a ruptured blood vessel and prevents further loss of blood. So it's basically trying to keep the body protected when a blood vessel is ruptured. So if you get a cut or even a hard hit that ends up being bruised, the blood vessels are being ruptured in that case, and then this is the process by which the body is going to prevent further blood loss and heal that area. So although the rupture of larger vessels usually requires medical intervention, hemostasis is effective for small, simple wounds. So a little cut, if you're cutting something up in your kitchen and cut yourself with a knife, a bruise, that kind of thing, prior to a bruise, the hit that causes a bruise kind of thing. There are 3 steps to the process. So the first part is a vascular spasm. Then we have the formation of a platelet plug, and then we have coagulation or blood clotting. And then if any of these steps of the process don't happen, then it can result in hemorrhage, which is excessive bleeding. So let's take a look at the first step, which is the vascular spasm. So when a vessel is severed or punctured, or when the wall of a vessel is damaged, vascular spasm occurs. So those things are important to note. So when a vessel is severed, so like a cut with a knife is going to cut through some capillaries, or punctured, so like a stick with a pin, which can cause some bleeding because you've punctured the wall of a blood vessel, or when the wall of a vessel is damaged, so that can be internal damage, meaning if there's some high blood pressure and then that high blood pressure damages the blood vessels, or if there is some sort of internal issues. So like if there's a bacterial infection or some sort of parasite that's damaging some blood vessels, then this same process is going to happen. It doesn't absolutely have to be something from an external type of source, like an actual cut or a stick or something. In vascular spasm, the smooth muscle in the walls of the vessels contract dramatically. So that's basically what's going on during vascular spasm, is the smooth muscle that are in the blood vessels. Remember, we have the different types of, we're going to talk more about that, I guess, in the vessels in the next section after the heart. So we'll look a little bit more closely at that, but we have circular muscles, circular smooth muscle that is going kind of like a rubber band around the blood vessel, and then we also have, in larger ones, longitudinal muscles that go the length of the blood vessel. So the smooth muscle has both circular layers, so layers like I was mentioning, like a rubber band around a blood vessel type of smooth muscle, and then the larger vessels have these longitudinal layers. So when a vascular spasm is going to happen, what is going on is we're taking those smooth muscle layers, the circular layers that are like a rubber band, and those are going to be tightening up, trying to cut off the blood flow to that area to constrict that so that it will decrease the amount of blood that is lost in this case. So the circular layers tend to constrict the flow of blood, and then in the case of longitudinal layers, if it's a large vessel, those large longitudinal layers are going to draw that vessel back into the surrounding tissue, kind of pulling it away from where the cut may have happened, for example, which in this case they mentioned can make it a little bit difficult for a surgeon to locate it because it's kind of pulled it into the tissue around it. To clamp it and to tie it off, that can become an issue. So the vascular spasm response is believed to be triggered by several chemicals called endothelins, and they are released by the vessel lining cells and by pain receptors in response to the vessel injury. So what we see is we have a cut, let's say for example, and then the vessel lining cells, right? So the cells that are lining the vessel of the blood vessel that was cut, and by pain receptors in that area, those two things are going to be releasing a chemical called endothelin. And then this chemical is going to be released, and then that's going to cause the smooth muscle in that area to contract, to constrict, and kind of tighten up that area to try to prevent the blood flow. So this phenomena, the vascular spasm part of this, lasts for up to 30 minutes, although it can last for hours. So typically up to about 30 minutes while the other steps of the process are occurring. So the next step is the formation of the platelet plug. So in the second step, we see the platelets come into consideration here. We talked about during platelets how they're important for coagulation, for blood clotting, In this case, the second step, platelets, which we mentioned are normally floating free in the plasma, they're going to encounter this area of vessel rupture. So they're going to be floating through the bloodstream, and then they're going to get to this point where there's been the cut or the rupture. And they're going to get to that area and to the underlying connective tissue and the collagenous fibers, and then they're going to start clumping together. So these sticky little platelet guys are going to start forming these little clumps. They're going to become spiky and sticky, and they're going to bind to that collagen and the endothelial lining. So they're going to start just creating this big lump of stickiness. This process is assisted by a glycoprotein called the von Willebrand Factor. So the von Willebrand Factor is going to assist in this. So it's going to help stabilize the growing platelet lumps, which in this case is called a platelet plug. So all of these platelets are coming down the bloodstream. They encounter this area. They're going to stick to the area, the endothelial lining, the exposed collagen from the cut, and they're going to stick to each other as well. And then this von Willebrand factor is going to be, this glycoprotein is going to help stabilize all of these platelets that are sticking together. So being a glycoprotein, glyco as a sugar and protein, so this sugar protein molecule is going to help stabilize the platelet plug. And then as these platelets collect, they are also releasing chemicals from the granules. Remember, there are some granules in the platelets, and they're going to release these chemicals, and then that's going to further contribute to hemostasis. So the platelets are just going to be floating along, they're going to get stuck, and then once they get stuck, they're going to send out little messages to other platelets to say, hey, come help. So that first one where I was mentioning, where it sends a message out to other platelets, they send out adenosine diphosphate, or ADP, and the ADP is going to help additional platelets adhere to this injury site. It's going to reinforce and expand this platelet plug. So the first platelets that kind of get stuck because they happen to be floating in that area are going to send out ADP, and it's going to tell other platelets to come over to this area, help them adhere to this site, and then it's going to reinforce it, so make it stronger and then make it bigger. They also release serotonin, and that's going to maintain vasoconstriction. So as those platelets are forming this platelet plug, it's going to be sending out this message via serotonin saying, hey, keep constricting, we're not done making this platelet plug here. Then also prostaglandins and phospholipids, which are also going to contribute to this vasoconstriction. They're also going to help activate further clotting chemicals, which we'll talk about in a moment. So also sending out saying, hey, keep constricting until we can get this platelet plug built up so we can stop the blood flow. Platelet plug temporarily seals this opening in the blood vessel, so this isn't the scab or the scarring tissue that we are used to seeing over time. This is an immediate response. So the first thing that happens is that vasoconstriction, just pulling that to try to cut off the blood flow to that area. And then we have platelet plug that's going to be building up as fast as it can to just try to stop that blood flow. So plug formation buys the body time while more sophisticated and durable repairs are being made. So this is kind of a quick fix, kind of stick stuff in there just to try to make sure that it doesn't lose too much blood. And then the next step here, our coagulation, is our more durable repairs. So we can talk about that. They did mention here, in a similar manner, even modern naval warships still have wooden plugs for temporary repair. So if there's some sort of puncture, they'll stick a plug in there until they figure out the best way to handle the situation. All right, so we're going to talk about coagulation now. So coagulation is also called blood clotting. And as mentioned here, these are the more sophisticated and durable repairs. So this is the more long-term fix. We've got the platelet plug now that's filling up that hole there, filling up the space. There's probably still a little bit of blood flow, but it's doing a good job of preventing a large amount of blood flow in the case, in this situation. So this is coagulation, this more durable long-term repair, which is the formation of a blood clot. So not a platelet plug, which is short-term, but a blood clot, which is more long-term. It's also it's sometimes characterized as a cascade because one event is going to prompt the next event. So it's kind of like a waterfall, as mentioned here. It's a multi-level waterfall. So we'll have one clotting factor that then will initiate other clotting factors and then other clotting factors to go through this process of coagulation. The result is the production of a gelatinous but robust clot made up of a mesh of fibrin. So we have fibrin, an insoluble filamentous protein. So a protein that's like filaments, right, that is insoluble, derived from fibrinogen. So we have our fibrinogen is going to turn into fibrin, and it's going to make like a mesh. This filamentous protein is kind of strandy, filaments, long strands, that's going to create like a web mesh in the area. So remember, we already talked about fibrinogen, the plasma protein that we talked about before, in which platelets and blood cells are trapped. All right, so let's take a look here. Let's see if I can make this a little bit smaller. I don't want to make it too small, but here we go. All right, so first at the top here we have our injury. As you can see, they say step 1. We're going to look at this side here first on the left. So injury is step number 1, right? So we have some sort of rupture here, some sort of cut is happening, the blood vessel is severed. And so our first of the 3 steps then, which here is number 2 because they count injury as number 1, is the vascular spasm. So here we can see we have these blood vessels here that are going to be tightening and kind of pulling those closed. You can see the difference here between how wide this is here and then tightening here. So the smooth muscle is going to contract near this injury point to try to reduce blood flow or blood loss. Then we have our platelet plug formation, which is actually the second step, step 3 here, because again, injury is number 1. Our platelet plug formation, where we have our platelets that are flowing through the blood vessels. So we have our platelets here. They're going to be flowing through, and then they're going to get stuck here. They're forming this platelet plug right here. So they come in contact with underlying collagen, and then they become sticky. You can see the little spikes on them. They're spiky and sticky, and they stick to each other and the wound site there. So the initial platelets we talked about are activated by chemicals released by these injured cells and by contact with the broken collagen, and that was the endothelin. And then the bound platelets release chemicals that activate and attract other platelets, and we talked about that as well. So then the platelets are all sticky here, and they're forming that platelet plug. Then step number 4 in this case, but 3 of hemostasis, is coagulation. So in coagulation, I'll try to move this up here, fibrinogen is converted to fibrin, and then that forms this mesh. So you can kind of see in here these little tiny strands here that is forming the mesh. And you can see even here in this really great photo here from a microscope that's forming this kind of mesh that also has blood cells stuck in it, platelets stuck in it, and it produces this clot to prevent any further blood loss. All right, so we're going to go back up and we'll take a look at this cascade here that's on the right side. But first I want to go through the words and we can talk about it, and then we can go up and look at the actual illustration there. So the clotting factors that are involved in coagulation, also called the coagulation cascade, it consists of several clotting factors that all kind of initiate each other, and we'll take a closer look at that. But the chemicals are called clotting factors or coagulation factors, and they prompt reactions that activate more coagulation factors. And so the process is complex, but there are 2 pathways that it starts from. So there are 2 initiation pathways. So one, there's the extrinsic pathway, which is normally triggered by trauma. So this is extrinsic, meaning triggered by trauma, to extravascular cells. So cells that are outside of the vascular, meaning the vessels. So this would be the tissue, like a cut to the tissue outside of the vessels. And then the second is the intrinsic pathway, which begins in the bloodstream. So this is triggered by internal damage to the walls of the vessels. So extrinsic is outside of the blood vessels, and intrinsic is due to damage to the actual blood vessels, the inside of the blood vessels. And this can be, for example, like the cut that went through the blood vessel. We would have both the extrinsic pathway occurring because of the tissue that was cut, and then the intrinsic pathway because of the actual blood vessel is also cut. But this can also mean just the intrinsic pathway can happen because of something like arterial disease, so atherosclerosis, damaging the tissue, high blood pressure, those kinds of things. And in that case, the extrinsic pathway would not be initiated. Both of these, the extrinsic and intrinsic, merge into a third pathway, which is referred to as the common pathway. So we have intrinsic, extrinsic, and then the common pathway. All three pathways are dependent upon the 12 known clotting factors, which includes calcium and vitamin K. So the clotting factors are secreted primarily by the liver and the platelets. So we already talked about how the platelets secrete some of them, and we'll talk about that again. The liver requires the fat-soluble vitamin K to produce many of them. So this is why perhaps you've heard that you need to have vitamin K in your diet. If you maybe bruise easily, or if your blood doesn't clot very quickly, you need to increase the vitamin K in your diet to try to initiate the production of more of these clotting factors. So if somebody is low in vitamin K, they're not taking in a lot of vitamin K, then they may take a long time to form this blood clot. However, vitamin K doesn't just come in our diet. Let's see, there's in the next sentence here. So with biotin and folate, it's not only consumed in the diet, here we go, but is synthesized by bacteria that reside in the large intestine. So we also have bacteria in our large intestine that are producing vitamin K for us. But again, in that case, it has to have the precursors, which we won't get into here, but you need to have the precursors of vitamin K. So it's important that you get it not only from the diet, but also that you have the precursors for the bacteria in the large intestine. The calcium ion is considered factor 4 and is derived from the diet. Right, so making sure that there's plenty of calcium is important, not only for building up bones, but also for clotting factors. And if there isn't enough in the diet, if there isn't enough floating around in the bloodstream, then we're going to pull it from the bone, from the breakdown of bone, in order to make clotting factors. Then they put in this little note here, some recent evidence indicates that the activation of various clotting factors occurs on specific receptor sites on the surfaces of platelets. So that the activation of these factors may start on specific sites on platelets. We won't talk about that too much. All right, so let's take a quick look here at the clotting factors. I do want to mention this here. So there are 12 clotting factors, numbered 1 through 13. So let's be very clear that there are 12 clotting factors. The reason they're numbered 1 through 13, it even mentions here, factor 6 was once believed to be a distinct clotting factor, but now it's thought to be identical to factor 5. So you can see in the chart down here, factor 6 is not used. They keep it in there so that they don't have to change the names of everything else, so they don't take 7, which has been around for years, and then all of a sudden now call that 6 and get very confusing. It would get very confusing reading older literature, newer literature. It would be very difficult. So they just kind of keep 6 in there. There are 12 clotting factors, but then we have this chart here that shows that there are 13, right? Because it's not actually 13, that's just labeled as such. So 1 through 13, because 6 is not used. It's the same as 5. Okay, so we're not going to go through this chart at the moment. We're going to talk about them, and then we can reference this chart as we're discussing the different clotting factors. All right, so first we'll talk about the extrinsic pathway, and then we'll talk about the intrinsic pathway. So the quicker responding and more direct extrinsic pathway, also known as the tissue factor pathway, because remember this is related to the tissues, like other tissues outside of the blood vessels, begins when damage occurs to the surrounding tissues, such as in traumatic injury. All right, so again, we're talking about outside of the blood vessel here. So when there is contact with the blood plasma, the damaged extravascular cells, which are extrinsic to the bloodstream, right, release factor 3, which is thromboplastin. So that's the start of our extrinsic pathway. There's damage to the cells, and then these cells that are damaged are going to release thromboplastin. Okay, so that's the beginning. Thromboplastin, factor 3 is released. This then is going to activate proconvertin. So it's going to activate calcium, then factor 7 proconvertin, which is activated by factor 3, right? So factor 3 is thromboplastin. It's going to activate calcium, then proconvertin, and then that's going to form an enzyme complex. Okay, so we have our number 3, thromboplastin, is released by the cells that are damaged, and then it's going to activate calcium and proconvertin, and then those 3 are going to form an enzyme complex. Then this enzyme complex, the 3 of them, are going to activate factor 10, which is the Stewart-Prower factor. Okay, so we've got those 3 form a complex, activation of factor 10, the Stewart-Prower factor, and then that's going to activate the common pathway. All right, so that's our extrinsic. Remember, both extrinsic and intrinsic go to the common pathway. So extrinsic are those steps, then goes to the common pathway, which we'll discuss in a moment. Okay, then we go to our intrinsic pathway. So remember, intrinsic meaning when the blood vessel itself is damaged, so that's triggered by internal damage to the blood vessels, so it begins in the bloodstream. So the intrinsic pathway, also known as the contact activation pathway, is longer and more complex. So extrinsic was pretty quick there. So remember, the factors are intrinsic to the bloodstream, so within the bloodstream. This can be prompted by damage to the tissue, so like a cut, or internal factors such as arterial disease. But is most often initiated when factor 12, the Hageman factor, comes into contact with foreign materials, such as when a blood sample is put into a glass test tube. So a lot of times this intrinsic pathway is when somebody is drawing blood, and then the blood hits a test tube, hits the non-body material, so in this case, like glass test tube. Within the body, factor 12 is typically activated when it encounters negatively charged molecules, such as inorganic polymers and phosphate produced earlier in the series of intrinsic pathway reactions. Okay, we're going to talk about this pathway. All right, so factor 12 sets off a series of reactions that in turn activates factor 11, which is anti-hemolytic factor C, or plasma thromboplastin antecedent. Okay, then factor 9, anti-hemolytic factor B, or B thromboplasmin. In the meantime, let's see, chemicals released by the platelets. Remember, the platelets are releasing their little granules and releasing chemicals. Increase the rate of these activation reactions. So remember, the platelets are going to initiate this and continue this going. So it's going to increase the rate of this. So then finally, factor 8, our anti-hemolytic factor A, from the platelets and endothelial cells, combines with factor 9, anti-hemolytic factor B, or plasma thromboplasmin, to form an enzyme complex that activates factor 10, the Stewart-Prower factor, or thrombokinase, leading to the common pathway. All right, so these things happen in a few minutes. So these events that we just talked about, and I'll summarize even more, happen within a few minutes. So we have our internal pathway, and it's like boom, boom, boom. All of these things are released within a few minutes and get to our common pathway. All right, so the intrinsic pathway, again, is internal damage that begins in the bloodstream, so damage to tissues like arterial disease or a cut, for example, when Hageman factor, the 12, clotting factor 12, comes into contact with foreign materials like a test tube. So ultimately, the intrinsic pathway is going to have anti-hemolytic factor A, right? So right here, number 8, clotting factor 8, anti-hemolytic factor A, from the platelets and the endothelial cells. They're going to combine with anti-hemolytic factor B, which is 9, right here, factor 9, anti-hemolytic factor B, or plasma thromboplasmin, to form an enzyme complex that activates thrombokinase, which is 10. Rather than Stewart-Prower, I most often use thrombokinase. So thrombokinase, and then that's going to activate the common pathway. So I guess within this intrinsic pathway, what I feel like it's important to understand is what I just kind of summarized. Rather than going through this series of reactions talking about anti-hemolytic factor C and then anti-hemolytic factor B here, or thromboplasmin, what I would like you to understand for the intrinsic pathway is when it's activated. So remember, within the bloodstream, we've talked about it multiple times now, the different things that might initiate it. And then what I would like you to understand, what I think is important to understand, is that ultimately what happens is we have anti-hemolytic factor A from the platelets, and the endothelial cells are going to combine with the anti-hemolytic factor B, and then they form this enzyme complex that then is going to activate thrombokinase, which is 10, factor 10. And then that thrombokinase is going to activate the common pathway. Okay, so then if we look up here, what you need to know for the extrinsic pathway is similar. We have our damaged cells, the extravascular cells that are outside of the vessels, are going to release factor 3, which is thromboplastin, and then that is going to initiate calcium being released, and then proconvertin, down here, our proconvertin being released, and then that's activated by factor 3, right, the thromboplastin, and then that's going to form that enzyme complex. So we have factor 3, calcium, and factor 7, proconvertin, are all going to form this enzyme complex, and then that's going to lead to the activation of our factor 10, our thrombokinase again. So the extrinsic pathway ends up at thrombokinase, the intrinsic pathway ends up at thrombokinase, both activating this common pathway. Okay? So both intrinsic and extrinsic pathways lead to the common pathway, in which fibrin is produced to seal off the vessel. So this is where we're getting to our fibrinogen is going to be converted to fibrin and is going to form this web. Once factor 10, the thrombokinase, has been activated by either the intrinsic or the extrinsic pathways, remember both of them lead to that common pathway, the enzyme prothrombinase converts factor 2, the inactive enzyme prothrombin, into the active enzyme thrombin. Okay? Just a side note, if the enzyme thrombin were not normally in an inactive form, clots would form spontaneously. So that's why we have to have this pathway. So we need to have this enzyme prothrombinase converting factor 2, which is the inactive enzyme prothrombin, into the active enzyme thrombin. So if we didn't have it in an inactive form floating around, we would just get blood clots all over the place. So instead we have prothrombin, which is inactive, floating around, and then we can initiate its activation, turning it into thrombin, which then will assist in coagulation or blood clots. So then thrombin is going to convert factor 1, fibrinogen, into fibrin. Okay? Then factor 13 stabilizes the fibrin clot. So again, thrombokinase is activated by the intrinsic and extrinsic pathway. So we end up at thrombokinase, and then this enzyme prothrombinase is going to convert prothrombin into the active enzyme thrombin, and then that's going to convert the fibrinogen into fibrin. And then those fibrin protein strands are going to work with our factor 13, which is our fibrin stabilizing factor, and then it's going to form that clot. Okay, so we can actually look up here just as a reminder of our chart here. Our 13 right here, our fibrin stabilizing factor is 13, and that's going to assist with the fibrin strands to stabilize fibrin and make that blood clot. All right, so going to here. All right, so fibrinolysis. There we are. So then our stabilized clot, here we are, our stabilized clot is acted upon by contractile proteins within the platelets. Right, so we have those proteins within the platelets. As these proteins contract, they pull on those fibrin threads. So remember, we have this mesh, this webbing of fibrin threads. It's going to pull on the fibrin threads, bringing the edges of the clot more closely together, so more tightly together. So kind of, they use the example of tightening loose shoelaces. So it's going to pull those things together. This process also wrings out of the clot small amount of fluid called serum, which is the blood plasma without its clotting factors. So it's just kind of the extra waterish stuff, the serum that's going to come out of that. To restore the normal blood flow, as the vessel heals, the clot must eventually be removed. All right, so this process is happening. We have our stabilized blood clot. We have our contractile proteins that are pulling that together in the platelets. It does release a little bit of the serum. And then, so we've gone through this process, and eventually we want this clot to be gone, right? Because we have healed this blood vessel. Oh, actually, let's go up here. Before we start doing that, let's go back up to our chart here, our flow, just as a reminder. The intrinsic pathway and extrinsic pathway. All right, so let's take a quick look at this, and then we'll talk about fibrinolysis. Sorry about that. So we have our extrinsic pathway, which, remember, is trauma to the extravascular cells. We have 3. These are the clotting factors, right? So our clotting factor 3, that is going to then initiate here. See, we're going down here. Well, I guess we don't have our intrinsic up here. There we go. All right, so our extrinsic pathway, we have our clotting factor 3, thromboplastin, which activates proconvertin, which is the 7, it activates that and combines with calcium, right, to make an enzyme complex. So our enzyme complex, and then we are going to move down, and then after we have initiated that enzyme complex, it's going to activate our 10, which is our thrombokinase, to activate then our final common pathway. Then we have our intrinsic pathway, which is the damage to the blood vessel walls. In our intrinsic pathway, we ultimately get down to our anti-hemolytic factor A, which is 8, okay? Anti-hemolytic factor A from the platelets and endothelial cells, and that's going to combine with our anti-hemolytic factor B, which is 9, and then it's going to form this enzyme complex. This complex is then going to activate 10, which is our thrombokinase, which is then going to go into our common pathway. Then, if we look at our common pathway, activated by the intrinsic and extrinsic pathways. Hopefully, I guess that's not going to get any more clear, is it? Oh, there we go. All right, so then our thrombokinase from our intrinsic and extrinsic pathways going to move into our common pathway. The enzyme prothrombokinase, or prothrombin, is going to convert the inactive prothrombin into thrombin. So we see that activation here. We have our thrombin then is going to convert our fibrinogen into fibrin, and then the insoluble fibrin, that's going to then be a part of our cross-linked fibrin clot, so that webbing factor. And then also that works with here our 13, which is our fibrin stabilizing factor. So they even show here the spiky ones are the factor in the active state, and the smooth ones are in the inactive state. So we have our active thrombin, our active fibrin, and then our active fibrin stabilizing factor. And then we have our cross-linked fibrin clot. All right, so now that we have our clot, let's move back down to fibrinolysis. Oh, there we go. All right, so fibrinolysis. So remember, we have our stabilized clot. We've gone through the process of making that. Now what we want to do is restore normal blood flow. So we're going to talk about fibrinolysis. So lysis, remember, is the breaking down, bursting, breaking apart. So fibrin is what was making those webs, right? The web, or the kind of the strands that were a big part of the clot. So the breaking down of fibrin is what this is, fibrinolysis. So the gradual degradation of the clot. So breaking down that clot so we can get the blood flow going again once it's starting to heal. A very complicated series of reactions that involves factor 12 and protein catabolizing enzymes. All right, so during this process, we have inactive protein, plasminogen, is converted into the active plasmin, which then is going to break down the fibrin of the clot. So again, if we had plasmin going around, it would just start breaking down clots all over the place. So we need our inactive form, plasminogen, and then converting that into our active plasmin. Then that's going to gradually break down the fibrin. Additionally, we have bradykinin, which is a vasodilator, is released. So that's going to reverse the effects of the serotonin and the prostaglandins that were released from the platelets. Remember, during our platelet plug, we release serotonin and prostaglandins from those platelets so that we have more vasoconstriction, which is tightening up those blood vessels, pulling the rubber band tighter to stop blood flow. Then now, in the process of wanting to increase blood flow, we have bradykinin. That's going to be a vasodilator, which is going to dilate the blood vessels or open up those blood vessels to increase the blood flow. So this allows the smooth muscle in the walls of the blood vessels to relax and helps to restore the circulation. So we have our inactive plasminogen converted to plasmin. That breaks down the fibrin. We have bradykinin, which is released. Then it's going to reverse serotonin and prostaglandins and allows those blood vessels to relax and open up and increase the blood flow. And then we also have up here, we have our platelets, right? Our stabilized clot is acted upon by those contractile proteins within the platelets, and it's pulling those fibrin threads, bringing the clot closer together, which then releases some of the serum that's kind of squeezed out while it's being tightened up, getting those things closer together so we can have more healing of that blood vessel. All right, so now we're going to talk about some of the plasma anticoagulants. So an anticoagulant is any substance that opposes coagulation, right? So something that's going to stop that coagulation process. So several circulating plasma anticoagulants play a role in limiting the coagulation process to the region of the injury. So again, we don't want this to happen all over the place, so we want to try to make sure it's only happening right where we need it, right at the site of the injury. So we have these anticoagulants that are flowing around, making sure that this isn't happening outside of that area. Also helpful in restoring a normal clot-free condition of the blood. So once a clot has happened, the body is going through the process of healing that blood vessel, and as that process is going on, we have our anticoagulants coming to break down that blood clot so that it's not stopping the blood flow anymore. So for instance, a cluster of proteins, collectively referred to as the protein C system, inactivates clotting factors that are involved in the intrinsic pathway. So tissue factor pathway inhibitor, TFPI, tissue factor pathway inhibitor, inhibits the conversion of the inactive factor 7 to the active form in the extrinsic pathway. So we have two different things here. So they are giving examples here of the anticoagulants. So we have, the protein C system, right, inactivates clotting factors that are in the intrinsic pathway. And then we have the tissue factor pathway inhibitor, or TFPI, is going to inhibit the conversion of the inactive proconvertin, that's the 7 here, proconvertin, to the active form in the extrinsic pathway. So it's going to stop that process, which then will stop the extrinsic pathway from continuing to get to the common pathway and then form that clot. Okay. Antithrombin inactivates our factor 10, which is our thrombokinase, and it opposes the conversion of prothrombin to thrombin, right? So remember, we had to take prothrombin and convert it to thrombin to continue with our clot process. So antithrombin, they all have the same kind of name there, is going to inactivate thrombokinase and oppose the conversion of prothrombin to thrombin in the common pathway. So in the common pathway. Also, we have basophils are going to release heparin, which we mentioned when we talked about the leukocytes. So this heparin released by the basophils is a short-acting anticoagulant, and that also works against or opposes prothrombin, converting to thrombin. This is found also on the surfaces of cells lining the blood vessels. And you may have heard of the pharmaceutical form of heparin is often administered therapeutically, so to surgical patients that are at risk for blood clots, so to try to prevent those blood clots from happening. All right, so now let's take a moment to look at some of the disorders of clotting. All right, so either an insufficient or an excessive production of platelets can lead to severe disease or death. So if we don't have enough, or if we have too many, as discussed earlier, an insufficient number of platelets called thrombocytopenia typically results in the inability of blood to form clots. So if we don't have enough platelets, then we are unable to form clots. And then this can lead to excessive bleeding, even from minor wounds. So even a small cut could pose a serious threat. Another reason for failure of the blood clot is inadequate production of the functional amounts of one or more of the clotting factors. So if we don't have those clotting factors for whatever reason, then we're not going to have that pathway, right? We're not going to have that cascade happen, either intrinsic, extrinsic, or even the common pathway. So this is the case in hemophilia, which is actually a group of related disorders. The most common one is hemophilia A, which is about 80% of the cases. So this results in the inability to synthesize sufficient quantities of factor VIII. Okay, so the most common one when we're talking about hemophilia, we're talking about the inability to synthesize our factor VIII, which is the anti-hemolytic factor A. So if we're unable to synthesize our anti-hemolytic factor A, then we're not able to go through that stepwise process. And then we're going to have a decrease in clotting, which can cause serious issues. Then there's also hemophilia B, the second most common form, about 20% of cases. In this case, there's a deficiency of factor IX, and factor IX is anti-hemolytic factor B. So both of these defects are linked to the X chromosome and are typically passed from a healthy mother to her male offspring. Okay, so since it is on the X chromosome and a male is an XY, it's only going to get one X. That X is going to be from its mother, and typically the mother will not have hemophilia. It'll just be a carrier. The mother is a carrier of the disease, and then they happen to pass along the X that has the hemophilia gene on it, and then that male, since it doesn't have another healthy X, is going to have hemophilia. So females would then need to inherit a defective gene from each parent to have the disease, since they are XX. So they would have to have a hemophilia X from the mother, that would be a carrier, and a hemophilia X from the father that would actually have hemophilia in order to have a female that has hemophilia. Patients with hemophilia bleed from even minor internal and external wounds, and they can leak blood into joint spaces after exercise, into the urine, and into the stool. So it can be a very serious situation. Then there's also hemophilia C. It's a more rare condition triggered by an autosomal chromosome, so not the X or the Y, not the sex chromosomes, but another chromosome that renders factor 11 non-functional. So 11 is anti-hemolytic factor C. And if you remember, anti-hemolytic factor C was part of the stepwise process that I didn't ask you to so closely remember, of that intrinsic pathway. It is not a true recessive condition, since even individuals with a single copy of the mutant gene show a tendency to bleed. So meaning that it's not a situation like the XY here of the other hemophilia, where if you have it, you have it, and if you don't, you don't. In this situation, since you get one from the mother, one from the father, if you have one from the mother or one from the father, but not both, then you can have a gradation of the disease. Regular infusions of clotting factors are isolated from healthy donors and then can help prevent bleeding in hemophiliac patients. Hopefully at some point we can do gene therapy, and then that won't be an issue at all. All right, so in contrast to the disorders characterized by coagulation failure is thrombocytosis. So we've already mentioned that, characterized by an excessive number of platelets And then that increases the risk for excessive clot formation, also known as thrombosis. All right, so excessive clot formation is called thrombosis. A thrombus is an aggregation of platelets, erythrocytes, and even white blood cells typically trapped within a mass of fibrin strands. So we're talking about basically the blood clot that we talked about, the platelets, the erythrocytes, even white blood cells that are all stuck within this mass of fibrin strands. That's a thrombus, okay? So while this is normal following the hemostatic mechanism, so if there's a cut, this creation, this thrombus, is normal, and we call that the blood clot within our torn, damaged blood vessels. In a large blood vessel, a thrombus will adhere to the vessel wall and decrease the flow of blood. So if we have a cut to a large vessel, then it'll adhere to the wall and decrease the flow of blood. And this is referred to as a mural thrombus. So if we have this process, right, and we create this thrombus, it can be flowing through the bloodstream, and then that thrombus can get stuck and adhere to a vessel wall, and it can decrease the blood flow. So that is a major condition. So if it decreases the blood flow, if it gets stuck in a small vessel, so in a small vessel, it can actually totally block the blood flow, and then that's termed an occlusive thrombus. So it's completely blocking the blood flow to that area, which is a serious issue. Of course, depending on the large vessel and how large the thrombus is, that can be a very serious issue also if you're not getting enough blood flow to different organs. But then an occlusive thrombus is where you're not getting any blood flow at all. Thrombi, plural, are most commonly caused by vessel damage to the endothelial lining, which activates the clotting mechanism. So we already saw that with the blood clotting, but in this case it's caused by blood vessel damage to the so that would be the intrinsic pathway going through the clotting situation, and then this whole mechanism is going to create this thrombus. Now, we just talked about it in the terms of there being an actual injury, but again, we can go through that intrinsic pathway, then the common pathway to form this thrombus, even if it's not a situation that necessarily you would say we would need it. So in the case of damage to the lining of the blood vessels, so if there is high blood pressure and it's pushed up against those cells and it's kind of roughened them up a bit, we can see this whole pathway happening. It can start causing these issues where we have blood clots that are forming because of just a roughening of the cells, because the body sees that as damage and needs to be fixed, but its response is so large that it ends up creating this thrombus, and then it doesn't have much to stick to because it's just a roughening of the cells. It's not a huge opening that needs this huge clot to be in there, and then it can cause a decrease in the blood flow of that area, or it can actually break loose and get stuck in a smaller vessel and then cause the decrease of blood flow, or the occlusion, an occlusive thrombus, and then stop blood flow completely. And actually, I think we talk about that more specifically down here in just a moment. So let's see, in a small vessel, it may actually totally block the blood flow. Thrombi are most commonly caused by blood vessel damage to the endothelial lining, which activates the clotting mechanism. These may include venous stasis, so when blood in the veins, particularly in the legs, remains stationary for long periods. So if things remain stationary for a long period of time, for example, long airplane flights can cause, in crowded conditions, may lead to deep vein thrombosis or atherosclerosis. And then that's an accumulation of debris in the arteries. And so if there's this accumulation of debris in the arteries, there's not much movement, this person's been sitting still for a long time, then this process can happen, and we can create these thrombi, which then can, once you start moving again, can get lodged somewhere and be very dangerous. Thrombophilia is also called hypercoagulation, so a condition where there's a tendency to form thrombosis. So hyper meaning increased, and then coagulation, right? So an increased coagulation, a tendency to form thrombosis. These may be familial, so genetic, or acquired. So acquired forms include autoimmune diseases, lupus. So if somebody has lupus, then this can be a problem. Immune reactions to heparin. So if there's an immune reaction there, like autoimmune disease, our immune system is trying to fight off disease. Polycythemia vera, which I think we talk about in just a moment in a little bit more detail, but polycythemia we've already talked about. Thrombocytosis, sickle cell disease, pregnancy, and even obesity. So all of these things can lead to a tendency to form thrombi, which are these chunks of blood clots that aren't actually in a damaged tissue, helping to kind of stop the blood flow to a cut or to an actual serious damage. A thrombus can seriously impede blood flow to or from a region and will cause local increase in blood pressure. So if the flow is to be maintained, the heart will need to generate a greater pressure to overcome the resistance. So again, if it's in a larger vessel and it's stuck in there and we have decreased blood flow, the heart is going to increase its pumping, increase the blood pressure to try to get past that. And then a lot of times that's when it'll be pushed against, and then it'll dislodge, which we'll talk about here in a moment. So a portion of the thrombus breaks free from the vessel wall and enters circulation. It's referred to as an embolus. So we have an embolus when a portion of the thrombus or the whole thing breaks free from the vessel wall and goes into circulation. So it's going through the blood and then can be carried elsewhere. So an embolus that is carried through the bloodstream can be large enough to block blood vessels critical to a major organ. All right, so we can see that getting stuck in various places, to the brain, to the kidneys, to the liver. When it becomes trapped, an embolus is called an embolism. So here are some examples in the heart, the brain, or the lungs. An embolism may accordingly cause a heart attack. So if we have an embolus, which is a thrombus that breaks free and is floating around, and if it breaks free and it's floating around, it's an embolus. And then the embolus, when it gets stuck somewhere, is an embolism. When that embolism happens in the heart, we have a heart attack. When it happens in the brain, we have a stroke. When it happens in the lungs, we have a pulmonary embolism. And then, of course, these are medical emergencies. A heart attack, a stroke, pulmonary embolism are very serious situations. Among the many known biochemical activities of aspirin is its role as an anticoagulant. So aspirin, acetylsalicylic acid, is very effective at inhibiting the aggregation of platelets. So it decreases the aggregation of platelets, which, as it mentions, is routinely administered during a heart attack or a stroke to reduce the adverse effects. So it's trying to stop those platelets from aggregating, try to break up that clot so you can get blood flow back to that area. As mentioned here, physicians sometimes recommend that patients at risk for cardiovascular disease take a low dose of aspirin to try to ensure that this doesn't happen, ensure that we don't get an embolism. All right, so however, this is important, I think, however, aspirin can also lead to serious side effects. So unless it seems like that is something that needs to happen, if a person has some sort of cardiovascular disease, it's important for them to take aspirin, as a physician may prescribe. However, people shouldn't just do this on their own because aspirin can lead to serious side effects, so including the increased risk of ulcers, for example. So if a person is a healthy person, they don't have this increased risk for thrombosis or embolism, then they don't need to take aspirin, and if they do, then it may actually cause ulcers. So it's important to be advised of that. A class of drugs collectively known as thrombolytic agents can help speed up the degradation of an abnormal blood clot. So if a thrombolytic agent is administered to a patient within 3 hours following a thrombotic stroke, the patient's prognosis improves significantly. So if somebody's able to get to the patient after they've had a thrombotic stroke, then hopefully they give a thrombolytic agent and then can increase that blood flow. However, some strokes are not caused by thrombi, but by a hemorrhage. So if the actual blood vessel in the brain breaks, then that would be a hemorrhage situation, not because of a decrease in blood flow, but because of a loss of blood. Thus, the cause must be determined before the treatment begins. So if somebody seems to be having a stroke, it could be either because there is a blood vessel that has broken and then it's hemorrhaging, the loss of blood decreases the blood flow to the brain, or because of a thrombus or thrombi, which is stopping the blood flow to the brain. In the case of the thrombi, it would be helpful to have a thrombolytic agent to break up that blood clot to get blood flow going again. However, if it's a hemorrhage, that would be the opposite, right? Because we wouldn't want to prevent a blood clot from forming in that case, and it would actually make things worse. So it's very important for that to be determined first. Tissue plasminogen activator is an enzyme that catalyzes the conversion of plasminogen to plasmin, which is the primary enzyme that breaks down clots. So it is released naturally by endothelial cells, but is also used in clinical medicine. So one of those thrombolytic agents would be this, for example. All right, so that is finishing up our section on talking about hemostasis and talking about breaking down of those blood clots. Now we're going to move into blood typing.